So first of all, I'd like to thank the organizing committee for inviting me. This afternoon, I will share my experience on the virus and NOS. I think it's unavoidable to talk about NOS and virus together because it's actually it's the same entity, and virus is now believed to be the subcategory of NOSes. Okay, so I will start with the case. It's a Thai boy, 7 years, 3 months, no significant medical or family history. He presented many years ago with a febrile illness, with vomiting and headache, 5 days before admission. And next day he got much better, no fever, it's all symptom resolved for the next 3 days. And then again, when after that, on 1 day before admission, he started having focal motor seizure, and very rapidly in the same day, the seizure became more often and clustered, and then evolved into generalized convulsion. And then he impaired consciousness, and at the time when he brought to you need to do a lot of more additional extensive investigation. Somehow the screen doesn't fit. So this is how to resolve it. Okay, but I go on. So if you finally find the cause of, if you finally find the cause, it may take a few weeks, in some cases. So you get to you get the cause, you get a specific treatment again. But around a significant number of patients, you cannot find the cause. That you define it as the cryptogenic NOS of virus. Okay. So to get a better frame of how to define NOS and virus for better research and for the clinical care for patients, so a group of experts will come up with all this definition a few years ago. So you can see that NOS is not a clinical disease. It's not a disease. It's just a clinical presentation, and it's not a specific diagnosis. So it just present in a patient who present with the refractory status and with no good reason. Okay, no underlying epilepsy, no brain disease, no toxic or metabolic cause that you can find from initial workup. But virus is also the subcategory of NOSes. You can see virus in all age, not only restrict to pediatric patients. Okay, but you need to have a fever, febrile infection between 2 weeks to 24 hours before the onset of refractory status. Okay, you don't need to have a fever at the onset of seizure. Okay, so with or without fever at the onset status. Okay, so in the pediatrics, usually pediatric NOS is 90% is virus because it's often come up with a fever. So cryptogenic NOS is a NOS of virus with unknown cause despite extensive investigation, as I talked before. Yeah. So when you deal with a patient with NOS of virus, the key thing is you have to look for the potential cause, like especially the treatable one. There are 3 groups of disease that definitely need to search for. Is number 1 is infection, a typical bacterial infection, or fungus, viral infection, parasite, something like that. Another cause that you definitely need to explore is the autoimmune encephalitis. This is one of the leading cause of identifiable cause of NOS and virus. Okay, so this is one is need to be very carefully looked for. And genetic disorder, especially the mitochondrial disorder, also can present with a NOS or virus. So the problem with searching for the cause of status is that there's so many of them. Professor Simon Chawan did the systemic review many years back that found that there's so many causes of status, more than 200 of them. And but to make it simple, you can group it in a few groups. Commonly is autoimmune, inflammatory, and genetics. Uncommon infection, drug and toxin. You can look for more detail in this publication. It's a nice summary of what the potential atypical causes of status. The Belgium group by Dr. Gaspard. So he did make a publication almost 10 years ago, 8 years ago. He's a summary of a patient from many centers across 5 to 10 years. And he got around 135 patients. So you can see that 135 patients in 5 to 10 years, you can see how rare the NOS is 5. NOS is it's quite rare. So, but it's come up with around half of them is cryptogenic. And around most common, the leading cause of NOS is paraneoplastic and autoimmune encephalitis. Another recent publication last year is also the systemic review of the patient from 2005 to 2022. Or it's along so he just published last year. So the finding pretty much the same. The cryptogenic cause is around half of them. And the leading cause is still autoimmune and paraneoplastic. So cryptogenic NOS is initially described in 2003 by the Belgian group. So after the initial description, there's so many publications, but it's a small series published. And then you can see that the NOS is present a small fraction of all status. But if you talk about refractory status, especially the super refractory, it can be comprised as it's quite common among this group of patients. For cryptogenic virus, the first description is by the French group many years ago, and you can see that there's so many different names in the past that, as an expert, previously believed that this is a different entity, it's different thing, from NOS. So and then after a few years, before, so they come up with the conclusion. This is that most experts now believe that this is the same entity. Virus is a subgroup of NOS, and define the name febrile infection-related epilepsy syndrome. So these two conditions share very common thing, natural cause the same. They start with a fever, 90% in children and around 30%, 40% in adults. And then the fever lasts a few days, and then when the fever comes down, that's where the seizure starts usually with a focal motor seizure. And then as the one I present to you at the beginning, they start a focal motor seizure, and then the seizure come very rapidly, frequent, and then evolve to generalized. And then the conscious impaired, they got intubated, mostly in the ICU. So this cause that we call acute seizure, acute epileptic cause, usually take a few days to a few months. During that time, during the acute seizure or acute epileptic phase, if you do the spinal tap, you can see some abnormality around 2/3 of the cases. Usually very mild, not to the level of you can expect from infection in the brain. Yeah. So and then the patient, either if the medication work or the seizure stop by itself after a few months or a few days, they go to chronic phase with no lucid interval, no, just go on to chronic phase. Okay, and then most of the case with NOS of 5, go have a drug-resistant epilepsy that we have to deal with, and half of them has a significant cognitive impairment and disability and stigma as well. Okay, so but mortality is less than kids, but in average in adults around 10 to 30%. If you look for if gonna be any specific MRI scan change on the MRI scan, one of the studies show that if you do the MRI scan at least 10 to 14 days after the seizure onset, you can see some change in bilateral cross-front. This finding not seen in other cause of status, So when you see this type of finding on MRI scan, it may be a clue that suggests that you deal with the loss of virus, okay? Because this finding not report in other cause, okay? But anyway, there's some other study does not support this thing. So this thing need to be clarified more. But again, it's a very important findings. Oh, sorry. Okay, why it happened? Still unknown, mostly unknown, but the concept is that minor viral illness lead to overreacting inflammatory response, okay? Possibly from genetic predisposition, Some studies show that there's some polymorphism in the gene coding for the cytokine, interleukin 1, something like that. So if you do spinal tap in this patient, you can see the elevated cytokine in many types of cytokine, and some of this cytokine is proconvulsant. And then this causes more seizure, and then the seizure also cause more releasing of cytokine, and then cause a vicious cycle, vicious loop, and then cause the patient to get a robust and massive seizure at the end, in very rapidly. So some patients have the genetics prone for inflammation from the seizure. You can see some studies show that some polymorphism in the gene coding the ASEAN sodium channel gene. Sorry. Okay. So regarding the treatment is very difficult. Usually the treatment is very difficult, so you follow the guideline for treatment of refractory status in the and then when at the end, as my patient that present, when you go to you fail the second line, third line, you have to suspect very quick that it might be the case of loss of virus, and then you have to start the treatment early, mostly in the 48 to 72 hours with methylprednisolone or IVIG or both. Or if you have a choice of plasma exchange, you can do that. Okay, and also if you fail the first line, you can go to the second line with the, if you very suspect the autoimmune encephalitis, the patient, even though you still haven't got the result back, but the patient have a movement disorder, psychotic presentation, and neurocognitive impairment, may be very likely suspect to be autoimmune encephalitis. So the second line should be rituximab. But if the patient present with very bad PO seizure, no movement disorder, no psychiatric presentation, just a PO seizure, you can go ahead with the more promising agent like supposed to be specific for loss of virus is interleukin 1 and 6 antagonist. But anyway, during that time, in the first week, ketogenic diet should be started, mostly in kids. But if in adult, if you have availability of ketogenic diet in adult, you should also start ketogenic diet because some experts think that this is a first-line treatment for NOS and virus. Again, ketogenic diet. There's some recent publication last 1 or 2 years ago. There's a review of kids who present with super refractory status, around 147 kids, and the seizure control is pretty much around 60%, and the serious side effects very minimal, or less than 5%. So it's quite a good treatment. But anyway, if you go for more specific treatment and promising agent is anakinra. Anakinra is an interleukin-1 receptor antagonist. So mostly used in children, and torizumab is an anti-interleukin-6 receptor antibody. So this one can usually in adult, but these two agents can be switched. If you fail anakinra, you can always follow by tocilizumab, and vice versa. Again, this also report or some case report or small case series with a small number of patients present with other alternate treatment with CBD, RNS, deep brain stimulation, long-term outcome, and VNS. Again, the result, when they report, the outcome seems to be good, but the result is the number of patients very small to conclude. Okay, so you can have a nice summary from in the paper published early this year, by the Professor Hirsch. This is a nice summary of what to do management of NOS and virus. So you can go look at that in detail. Let's go back to the case. The case, he got all the treatment, all the anti-seizure medication. All of them, I think, include the pyrampanel, loading dose, or ketogenic diet, plasma pheresis, methylpenicillin, IVIG, plasma exchange, pentobab, thiopental, propofol. So after 2 months, everything he failed. So in this case, at the end of 2 months, so still some, because some publication report some efficacy of CBD. So try to find CBD, to use for the patient. But at that time, it's many years ago, so CBD is still not legal at that time. So still need to get a lot of effort to get it. Okay, and then when you get it a month later, seizure stop after 5 days, and then thiopental can stop after day 7 of CBD, and the genetics come up at the time show that some pathogenic mutation, and also at this time after a few years he's still on follow-up. He has one seizure every few months, and he go back to school, has normal life, and has a quite modest cognition. So this may be, I'm not sure it's a seizure stop by itself, or from CBD, but because after a few months it's a time to stop, but it's hard to conclude. But anyway, it's just in consideration. So that's where I conclude my talk. Thank you very much.